Hello everyone, welcome to PharmaGrid. So today we are going to learn about the pharmacology of opioids. The term opium refers to a mixture of alkaloids from the poppy seed. Morphine is a plant alkaloid isolated from the latex of opium poppy known as Papaver somniferum. The name opium was derived from the Greek word opos, which means juice. The compounds derived from morphine are generalized as opioids, or this opioid is a term used broadly to describe all compounds that work at the opioid receptors. And these endorphins are the endogenous peptide ligands found in the brain for opioid receptors. Opioids are natural, semi-synthetic or synthetic compounds that produce morphine-like effects. All opioids act by binding to specific opioid receptors in the central nervous system to produce effects that mimic the action of endogenous peptide neurotransmitters. Examples for these endogenous peptide neurotransmitters include endorphins, enkephalins, and dynorphins. And the primary use of these opioids are to relieve intense pain that results from surgery, injury, or chronic disease. Unfortunately, widespread availability of opioids has led to abuse of agents with euphoric properties. So coming to the classification of opioids, the first classification is based on the origin. So based on the origin, opioids can be classified as natural, semi-synthetic or synthetic. Natural opioids include morphine and codeine. Semi-synthetic opioids include buprenorphine, hydromorphone, hydrocodone, oxycodone and oxymorphone. And synthetic opioids include fentanyl, meperidine, methadone, tapentadol and tramadol. Opioids can further be classified by their actions. Okay, so based on their actions, opioids can be further classified into agonist, agonist bar antagonist, or partial agonist or antagonist. Compounds can have intrinsic affinity and efficacy at receptors, with affinity being a measure of the strength of interaction between a compound binding to its receptor, and efficacy being a measure of the strength of activity or effect from this binding at the receptor. Okay, so this agonist, antagonist, or partial agonist classification is based on the intrinsic affinity as well as efficacy of opioids at their receptors. So affinity means it is a measure of strength of interaction between a compound binding to its receptor, whereas efficacy means response or effect. Efficacy being a measure of the strength of activity or effect or response from this binding at the receptor. So an agonist has both affinity and efficacy. An antagonist has affinity but it has no efficacy. No efficacy or no response or effect is produced by the antagonist. A partial agonist has affinity. Affinity means it has got higher interaction with the receptor but only partial efficacy or partial effect is produced by a partial agonist. So the next classification is based on the pharmacological classes of opioids and their actions on the opioid receptors. So phenanthrene derivatives includes morphine, codeine, oxycodone, oxymorphone, hydromorphone, hydrocodone, levorphanol, buprenorphine, nalbuphine, butorphanol and naloxone. Pentazocine is a benzmorphine derivative and phenylpiperidines include fentanyl, alfentanyl, remifentanil, sufentanil and meperidine. Methadone is a diphenyl heptane derivative. And phenylpropylamines include tramadol and tapentadol. And here you can see their actions on the opioid receptors as well. So this morphine, codeine, oxycodone, oxymorphone, hydromorphone, hydrocodone, levorphanol, all these are agonists. Agonist means they have got both efficacy as well as affinity. And this buprenorphine is a partial agonist bar antagonist. Nalbuphine is a mixed agonist bar antagonist. Butorphanol is also the same, that is mixed agonist antagonist. Naloxone is an antagonist. Antagonist means it has got affinity but no efficacy. Pentazocine is a mixed agonist bar antagonist, and all these phenylpiperidine derivatives, then methadone, tramadol, tapentadol, all these are agonists. Pure opioid antagonists, for example morphine, hydromorphone, fentanyl, stimulate mu receptors and are the most potent analgesics. As the dose is increased, analgesia theoretically occurs in a log linear fashion. The degree of analgesia induced is limited only by intolerable dose-related adverse effects. In contrast, opioid agonist bar antagonist and opioid partial agonist, for example buprenorphine, pentazocine, nalbuphine, butorphanol, nalorphine, exhibit a ceiling effect on the degree of analgesia that they can produce. So ceiling effect means it is a pharmacological phenomenon that occurs when a drug reaches its maximum effect, and increasing the dose does not result in any further benefits or side effects. Okay, so this is what is known as ceiling effect, and this concept is particularly relevant for medications like buprenorphine, which have a ceiling effect that reduces the risk of overdose. Specifically, buprenorphine's safety is conferred by ceiling effects for respiratory depression, sedation, and subjective measures such as euphoria, making it a very safe option for opioid use disorder treatment. Then this opiate agonist or antagonist and partial agonist can precipitate opioid withdrawal reactions. The respiratory depressant effects of partial agonist are not completely reversed with naloxone. So examples for strong agonists include alfentanyl, fentanyl, heroin, morphine, hydrocodone, hydromorphone, levorphenol, meperidine, methadone, oxycodone, oxymorphone, remifentanil and sufentanil. Codeine is a moderate or low agonist. The mixed agonist, antagonist and partial agonist examples include pentazocine, buprenorphine, butorphanol and nalbuphine. Then opioid antagonists include naloxone and naltrexone. Tramadol and tapentadol comes under other analysis. So in this diagram you can see a comparison of the opioid agonist efficacy. So they can be classified into high, moderate as well as low agonist efficacy. And here you can see the most simplified classification of opioids. So this opioid analgesics and antagonists, they can be broadly classified into opioid mu receptor agonist, complex action opioids and pure opioid antagonist. So under this opioid mu receptor agonist, further classified into natural, semi-synthetic and synthetic opioids. Natural opium alkaloids include morphine and codeine. Then semi-synthetic opioids include heroin, codeine and ethyl morphine. Another name for this heroin is diacetyl morphine. Then synthetic opioids include pethidine. Another name for pethidine is meperidine. Then methadone, fentanyl, dextromethorphan and tramadol. Then complex action opioids can be further subdivided into agonist antagonist, also known as kappa analgesics, and partial mu agonist plus kappa antagonist. Here example is buprenorphine, and agonist antagonist examples include nalorphine, pentazocine and butorphanol. Now the last one is pure opioid antagonist. Examples include naloxone, naltrexone and nalmefene. Now moving on to the opioid receptors. These opioid receptors are members of the G protein coupled receptor family and inhibit adenyl cyclase. Okay, so these opioid receptors are G protein coupled receptors. Three main receptor families commonly designated as mu, kappa and delta. Okay, so the three main opioid receptors include mu, kappa and delta. There are opioid receptors within the CNS as well as throughout the peripheral tissues. These receptors are normally stimulated by endogenous peptides. Examples for endogenous peptides include endorphins, enkephalins and dynorphins. These endogenous peptides are produced in response to noxious stimulation. Okay, so these opioid receptors are G protein coupled receptors. Three main opioid receptors include mu, kappa and delta. And these opioid receptors are present within the CNS as well as throughout the peripheral tissues, and these receptors are normally stimulated by the endogenous peptides such as endorphins, enkephalins and dynorphins in response to noxious stimulation. So in the last slide we have learned about the endogenous neuropeptides, examples including enkephalins, endorphins and dynorphins. Enkephalins are derived from proenkephalin and are relatively selective delta ligands. Endorphins are derived from pro-opiomelanocortin and bind to the mu receptor, and these dynorphins are derived from pro-dynorphins and are highly selective at the mu receptor. So in this slide you can see the functions as well as locations of the opioid receptors. So the three main opioid receptors include mu, delta and kappa, and here you can see their corresponding functions. Suppose for example for mu receptors the functions include spinal, supraspinal analgesia, then sedation, inhibition of respiration, decreased intestinal transit rate, regulation of hormone and neurotransmitter secretion. And here you can see the location of the mu receptors such as brain. In the brain, these mu receptors are mainly located in the thalamus, caudate, amygdala, then raphe nuclei, gray matter, hippocampus, etc. And then dorsal horn, peripheral terminals, small intestine, etc. And then coming to the delta receptors, functions include supraspinal and spinal analgesia, then regulation of the secretion of hormones and neurotransmitters. And these delta receptors are mainly located in the cortex, amygdala, hypothalamus and midbrain region of the brain, and also in the spinal cord. Then coming to the kappa receptors, its main function including supraspinal and spinal analgesia, then psychomimetic effects, then decreased gastrointestinal transit. And these kappa receptors are located in brain, the areas such as cortex, thalamus, hypothalamus, gray matter, black matter, caudate and putamen. So you can refer this slide in order to learn the functions as well as the locations of the different opioid receptors. Moving on to the mechanism of action of mu opioid receptor agonist. As I have already mentioned, all three opioid receptors are members of the G protein coupled receptor family and inhibit adenyl cyclase. So different genes control each of the three major opioid receptors. So here you can see the structure of an opioid receptor. Each receptor consists of an extracellular N terminus, 7 transmembrane helical twists, 3 extracellular and intracellular loops, and an intracellular C terminus. Okay, so this is how the opioid receptor looks like. So once the receptor is activated, it releases a portion of the G protein, which diffuses within the membrane until it reaches its targets, and this target can be either an enzyme or an ion channel. So what these targets will do? These targets alter protein phosphorylation via inhibition of cyclic AMP. The cyclic AMP acts as a secondary messenger within the cell, resulting in the activation of protein kinases. Activation of the opioid receptor decreases the calcium influx. Calcium influx means calcium entry in response to incoming action potential. This decreases the release of excitatory neurotransmitters such as glutamate. And secondly, activation of the opioid receptor increases the potassium efflux. Potassium efflux means potassium will go out. Okay, it will result in hyperpolarization and decreases the response of the postsynaptic neuron to excitatory neurotransmitters. Okay, so here in this diagram you can see that morphine when bind to its opioid receptor, it inhibits the adenyl cyclase. As a result, there will be decreased cyclic AMP. Okay, it acts as a second messenger. This decreased cyclic AMP results in two conditions. First one, there will be decrease in the calcium influx. Okay, so calcium entry will be blocked. As a result, what will happen? This decreases the release of excitatory neurotransmitters such as glutamate. And secondly, what will happen? Potassium channels get opened, which means it increases the potassium efflux. Potassium will go out. So as a result, it will decreases the response of the postsynaptic neuron to excitatory neurotransmitters. So this is how the opioid drugs are acting. Next, we will learn about the pharmacological actions of opioids. So the first one is analgesia. Morphine and other opioids relieve pain by raising the pain threshold at the spinal cord level and by altering the brain's perception of pain. Second action is euphoria. Euphoria means it is a powerful sense of contentment and well-being. Euphoria may be caused by disinhibition of the dopamine containing neurons of the ventral tegmental area. In normal pain-free individuals, analgesic doses of morphine can cause dysphoria. Dysphoria means it is an opposite of euphoria. Next one is in the respiratory center. So in the respiratory center, this opioid drugs will cause respiratory depression. How? By reduction of the responsiveness of the medullary respiratory center neurons to carbon dioxide. Respiratory depression is the most common cause of death in acute opioid overdoses. And the next action is depression of the cough reflex. Both morphine and codeine have antitussive properties. Antitussive properties means cough suppressing properties. The receptors involved in the antitussive action appear to be different from those involved in analgesia. So the next one is meiosis. The pinpoint pupil characteristic of morphine users results from stimulation of mu and kappa receptors at the Edinger-Westphal nucleus. There is little tolerance to this effect. This is important diagnostically because many other causes of coma and respiratory depression produce dilatation of the pupil. Okay, so in this diagram or in this image, you can see the characteristic pinpoint pupil associated with the morphine use. Okay, so this is very important. Pinpoint pupil is one of the important diagnostic feature of this opioid poisoning or opioid overdose. Next one is emesis. Morphine directly stimulates the chemoreceptor trigger zone in the area prostrema that causes vomiting. In the gastrointestinal tract, opioids will decrease the gastrointestinal motility, increase the tone of the intestinal circular smooth muscle, and increases the tone of the anal sphincter. So altogether resulting in the constipation with little tolerance developing. So not the point. In the gastrointestinal tract, the opioids will cause constipation. Then coming to the biliary tract, in the biliary tract, opioid drugs will increase the biliary tract pressure due to contraction of the gallbladder and constriction of the biliary sphincter, which is a sphincter of OD, and thereby it can aggravate the biliary colic pain. So coming to the cardiovascular system, hypotension and bradycardia may occur at higher doses. Because of respiratory depression and carbon dioxide retention, cerebral vessels dilate and increase the cerebrospinal fluid pressure. So let's see. Morphine will cause this respiratory depression. So as a result of respiratory depression, it will cause carbon dioxide retention. This carbon dioxide retention will result in cerebral vasodilatation. As a result, it will lead to increased intracranial tension or increased cerebrospinal fluid pressure. So this morphine is usually contraindicated in individuals with head trauma or severe brain injury. Next pharmacological action is the histamine release. So this morphine in the sense any opioid drugs, it releases histamine from mast cells causing urticaria, sweating and vasodilatation. So because these opioid drugs can cause bronchoconstriction, morphine is a prototype of this opioid drugs. So this morphine should be used with caution in patients with asthma. Coming to the hormonal actions, if these opioid drugs are used for a prolonged period, it can cause opioid-induced androgen deficiency. How this will occur? Due to the suppression of the hypothalamic pituitary gonadal axis, which is the HPA axis. This results in decreased production of sex hormones, especially testosterone, resulting in many clinical symptoms. So here you can see the clinical symptoms associated with the opioid-induced androgen deficiency. The symptoms include sexual dysfunction, fatigue, hot flashes, depression, weight gain, decreased muscle mass, osteoporosis and possible infertility. Next one is labor. Morphine may prolong the second stage of labor by transiently decreasing the strength, duration and frequency of uterine contractions. Next is the thermoregulation. Morphine decreases the body temperature slightly due to its effect on hypothalamus heat regulating mechanisms. Okay, so this opioid drugs will cause hypothermia. Hypothermia means decrease in the body temperature. Next, in the urinary bladder, these drugs will inhibit the urinary voiding reflex. So as a result, what will happen? Urinary retention, especially in elderly males with a prostatic hypertrophy. So this opioid drugs will cause urinary retention. Then coming to the immune system, morphine shows both direct and indirect effects through the centrally mediated neuronal mechanisms on the immune system. Opioids in general cause moderate immunosuppression, which makes the recipient susceptible for infections and tumor metastasis. So in this slide, you can see a summarization of the pharmacological effects of opioid drugs. And you can use this mnemonic, that is morphine CVS, to learn the pharmacological effects of opioids, where M stands for meiosis, then A stands for the analgesic property, and R for respiratory depression, P stands for physical and psychological dependence, H for histamine release, hypotension and hypothermia, then I stands for increased intracranial pressure, N for nausea and vomiting, E for euphoria. Then C stands for cough suppression, which is the antitussive property, and constipation. Then V stands for vagal stimulation, which results in bradycardia. Then S stands for sedation and hypnosis. Therapeutic uses of opioid drugs. So the first one is analgesia. Opioids are used for pain in trauma, cancer and other types of severe pain. Next use is treatment of diarrhea. Opioids decrease the motility and increase the tone of intestinal circular smooth muscles. That is, agents commonly used include diphenoxylate and loperamide. Next therapeutic use is for the relief of cough. Codeine and dextromethorphan are more commonly used as antitussive agents. Next, for the treatment of acute pulmonary edema. Intravenous morphine dramatically relieves dyspnea caused by pulmonary edema associated with the left ventricular failure, possibly via the vasodilatory effect. This in effect decreases the cardiac preload and afterload as well as anxiety experienced by the patient. So the next use is for the anesthesia. Opioids are used as pre-anesthetic medications for systemic and spinal anesthesia and for post-operative analgesia. Pharmacokinetics. So the first one is administration. Morphine has a linear pharmacokinetic profile. However, absorption of morphine after oral administration is slow and erratic. Extended release oral preparations provide more consistent plasma levels. Because significant first pass metabolism of morphine occurs in the liver, subcutaneous and intravenous injections produce the most reliable response. So not the point here. So morphine is a drug which undergoes significant first pass metabolism. Coming to the distribution, morphine rapidly enters all body tissues including the fetuses of the pregnant woman. It should not be used for analgesia during labor. Infants born to addicted mothers show physical dependence on opioids and exhibit withdrawal symptoms if opioids are not administered. Morphine is the least lipophilic of the common opioids. Lipophilic means lipid loving. Okay, so by contrast, the more lipid soluble opioids such as fentanyl and methadone readily penetrate the central nervous system. Next is the fate or otherwise known as metabolism. Morphine is conjugated with the glucuronic acid in the liver to two active metabolites. Okay, so the two active metabolites of morphine are morphine 6 glucuronide and morphine 3 glucuronide. Both are renally excreted. This morphine 6 glucuronide is a very potent analgesic, and morphine glucuronide metabolites undergo enterohepatic circulation. Morphine 3 glucuronide does not have analgesic activity, but it is believed to cause neuroexcitatory effects. The duration of action of morphine is 4 to 5 hours when administered systemically to opioid naive individuals, but considerably longer when injected epidurally because the low lipophilicity prevents redistribution from the epidural space. Okay, so the important point is that morphine has got two active metabolites. Okay, so the first one is morphine 6 glucuronide, which is active. Okay, this morphine 6 glucuronide is a very potent analgesic, and the second active metabolite is morphine 3 glucuronide. This morphine 3 glucuronide does not have analgesic activity, but it is responsible for causing the neuroexcitatory effects. Next is about the adverse effects of these opioids. These adverse effects can be correlated with the pharmacological actions of opioids. So, one of the most important problem associated with these opioids is the tolerance and physical dependence. Repeated use produces tolerance to the respiratory depressant, analgesic, euphoric, emetic and sedative effects of morphine. Tolerance usually does not develop to meiosis. Meiosis means constriction of the pupils or constipation. Withdrawal produces a series of autonomic, motor, and psychological responses such as goosebumps, muscle spasms, hyperalgesia, lacrimation, rhinorrhea, yawning, sweating, restlessness, dilated pupils, anorexia, irritability, tremors, diarrhea, and flushing that can be severe. Okay, so these all are the withdrawal symptoms. Next, one of the most important problem is opioid-induced constipation, which is a common adverse effect. Initial management includes a non-prescription stimulant laxative such as senna. Peripherally acting mu-opioid receptor antagonists such as methyl naltrexone, naloxone and naltimidine are prescription drugs available for the treatment of opioid-induced constipation. Lubiprostone is a chloride channel activator that is indicated for opioid-induced constipation and irritable bowel syndrome. Contraindications or cautions. So this opioid drugs should be used with caution in patients with liver disease and renal dysfunction. Respiratory drive may be suppressed in patients with respiratory disorders such as obstructive sleep apnea, emphysema or cor pulmonale. So close monitoring is necessary when using opioids. Then other contraindications include bronchial asthma, head injury and hypotensive states. Then moving on to the drug interactions, the depressant actions of morphine are enhanced by co-administration with CNS depressant medications such as phenothiazines, monoamine oxidase inhibitors and benzodiazepines. A black box warning also has been included on the labeling of both opioids and benzodiazepines to alert prescribers of this dangerous combination. So in this slide, you can see the drug interactions of opioids. So the drugs mainly interact with opioids include CNS depressant drugs, then enzyme inducers as well as enzyme inhibitors. You can refer this image for drug interactions associated with the opioids. Now we are going to discuss each drug in detail. So the first one is codeine. It is a weak analgesic used for mild to moderate pain. The analgesic actions of codeine are derived from its conversion to morphine by the CYP2D6 enzyme. Okay, so this is a point to be noted down. Okay, so the codeine gets converted to morphine by which isoenzyme? By CYP2D6 isoenzyme. Okay, so these analgesic actions of codeine are derived from its conversion to morphine by the CYP2D6 enzyme. Life-threatening respiratory depression and death have been reported in children who received codeine, mostly following tonsillectomy and/or adenoidectomy. It is commonly used in combination with acetaminophen for management of pain. It exhibits good antitussive activity at doses that do not cause analgesia. Usual adult dose for pain is initial dose 15 to 60 mg orally up to every 4 hours as needed. Maximum dose is 360 mg in 24 hours. So the next drug is dextromethorphan. It belongs to the morphinan class with sedative, dissociative and stimulant properties at lower doses. It is used mainly as a cough suppressant for the temporary relief of cough associated or caused by minor throat and bronchial irritation. It is available in combination with other drugs such as paracetamol, ibuprofen, a nasal decongestant or an antihistamine in many over-the-counter cold and cough medicines. It is available as in various dosage forms such as syrup, lozenges, tablets and spray. Dextromethorphan should not be used for chronic cough as seen with smoking, asthma or emphysema, or when there is an unusually large amount of mucus or phlegm with the cough. At doses exceeding approved dosages, dextromethorphan acts as a dissociative anesthetic. It acts by multiple mechanisms of action, including actions as a sigma-1 receptor agonist and non-selective serotonin reuptake inhibitor. At high doses, dextromethorphan and its major metabolite, the major metabolite of dextromethorphan is dextrorphan, also acts as an NMDA receptor antagonist. Then this drug is rapidly absorbed from the gastrointestinal tract and converted into the active metabolite dextrorphan in the liver by the CYP2D6 isoenzyme. And the elimination half-life of dextromethorphan is about 4 hours approximately in individuals with an extensive metabolizer phenotype. This is increased to approximately 13 hours when it is given in combination with the quinine. And this drug should not be administered to children below 4 years and it is contraindicated in atopic children. The side effects of this drug include rash or itching, nausea, vomiting, constipation, diarrhea, drowsiness, dizziness, sedation and confusion, and rarely it may cause respiratory depression. Okay, so this is one of the advantage of this dextromethorphan. It rarely causes respiratory depression. Then usual adult dose for cough is immediate release dosage form 10 to 20 mg orally every 4 hours or 30 mg orally every 6 to 8 hours. Then extended release preparation, the dosage is 60 mg orally every 12 hours. Then maximum dose is 120 mg in 24 hours. Moving on to the next drug, which is noscapine. Antitussive effects of noscapine is through the activation of sigma opioid receptors without narcotic, analgesic or dependence inducing properties. It is registered for the treatment of a dry, non-productive cough and it is available as a syrup and a tablet. Anti-mitotic effect by binding to tubulin that causes cell cycle arrest and potentially promotes apoptosis both in vitro and in vivo in cancer cells. Then side effects include headache, drowsiness, nausea, bronchoconstriction and rashes. Then this drug increases the effects of centrally sedating substances such as alcohol and hypnotics. This noscapine should not be taken with any monoamine oxidase inhibitors and with warfarin as the anticoagulant effects of warfarin may be increased. Oxycodone and oxymorphone. This oxymorphone and oxycodone are orally active semi-synthetic analogues of morphine and codeine respectively. That is, oxymorphone is the semi-synthetic analog of morphine, whereas this oxycodone is the semi-synthetic analog of codeine. Oxymorphone given parenterally is approximately 10 times more potent than morphine, but when administered orally, the potency drops to about 3 times that of morphine. Then this oxymorphone is available in both immediate release and extended release oral formulations. This agent has no clinically relevant drug interactions associated with the cytochrome P450 enzyme system. Then this oxycodone is approximately 2 times more potent than morphine. It is available in an immediate release formulation alone or in combination with acetaminophen, aspirin or ibuprofen. An extended release formulation is also available. Oxycodone is mainly metabolized via the CYP2D6 and CYP3A4 enzymes. Hydromorphone and hydrocodone. These drugs are orally active, semi-synthetic analogues of morphine and codeine respectively. Oral hydromorphone is approximately 4 to 7 times more potent than oral morphine. It is preferred over morphine in patients with a renal dysfunction due to less accumulation of active metabolites. Then this hydrocodone is a methyl ether derivative of hydromorphone but is a weaker analgesic than hydromorphone. This agent is often combined with acetaminophen or ibuprofen to treat moderate to severe pain. It is also used as an antitussive. Hydrocodone is metabolized in the liver to several metabolites, one of which is hydromorphone via the actions of CYP2D6. So the next one important opioid drug is fentanyl. It is a synthetic opioid chemically related to pethidine. It has got 100-folds the analgesic potency of morphine and it is used for anesthesia and acute pain management. It is highly lipophilic. Highly lipophilic means so it can easily penetrate the CNS and has a rapid onset and short duration of action, that is 15 to 30 minutes. It is usually administered IV, epidurally or intrathecally. This fentanyl is combined with local anesthetics to provide epidural analgesia for labor and post-operative pain. IV fentanyl is used in anesthesia for its analgesic and sedative effects. Many fast-acting transmucosal and nasal fentanyl products are available for cancer-related breakthrough pain in opioid-tolerant patients. The transdermal patch creates a reservoir of the drug in the skin and has a delayed onset of at least 12 hours and a prolonged offset. The patch is used for the management of chronic or severe pain. Fentanyl is metabolized to inactive metabolites by CYP3A4, and drugs that inhibit this isoenzyme can potentiate the effect of fentanyl. So the dose of this fentanyl in various conditions include: first one, for the surgery pre-medication, 50 to 100 microgram per dose IM or slow IV 30 to 60 minutes prior to surgery. Then in case of general anesthesia, for minor surgical procedures, 0.5 to 2 microgram per kilogram per dose IV. For major surgery, 2 to 20 microgram per kilogram per dose initially, then 1 to 2 microgram per kilogram per hour maintenance infusion IV. Discontinue infusion 30 to 60 minutes prior to end of surgery. Limit total fentanyl doses to 10 to 15 microgram per kilogram for fast tracking and early extubation. Then in case of severe pain, the dose of fentanyl is 50 to 100 microgram per dose IV or IM, Q1 to 2 hour PRN. PRN means as needed. Patients with prior opioid exposure may tolerate higher initial doses. So the fentanyl transdermal patches are available in various strengths such as 12 microgram per hour, 25 microgram per hour, 50 microgram per hour, 75 microgram per hour and 100 microgram per hour. And this fentanyl transdermal patch is indicated for chronic pain in opioid tolerant patients severe enough to require daily round the clock long-term opioid treatment and for which alternative treatment options are inadequate. Then this discontinue or taper all other extended release opioids when beginning fentanyl transdermal therapy. So the normal dose of this fentanyl transdermal patch is 25 to 100 microgram per hour, reapplied Q72 hour until adequate analgesia is achieved. So each fentanyl transdermal patch may be worn continuously for 72 hours. 72 hours means 3 days. Then this rotate application sites to a different skin site after removal of the previous transdermal system. Next, we will learn about the synthetic opioid agonist related to fentanyl, which includes sufentanil, alfentanil, remifentanil, and carfentanil. These agents differ in potency and metabolic disposition. Sufentanil and carfentanil are even more potent than fentanyl, whereas the other two are less potent and shorter acting. Sufentanil, alfentanil, and remifentanil are mainly used for their analgesic and sedative properties during surgical procedures requiring anesthesia. Carfentanil is about 100 times more potent than fentanyl. The drug is not used in clinical practice. Next drug is methadone. It is a synthetic orally effective opioid mu agonist and antagonist of the NMDA, that is N-methyl D-aspartate receptor, and a norepinephrine and serotonin reuptake inhibitor. So regarding the methadone, its mechanism of action is it is a mu agonist, then NMDA receptor antagonist, and a norepinephrine and serotonin reuptake inhibitor. This methadone is useful in the treatment of both nociceptive and neuropathic pain. Then it is used for opioid withdrawal and maintenance therapy in the setting of prescription opioid and heroin abuse. The withdrawal syndrome with methadone is milder but more protracted, in the sense days to weeks, than that with other opioids. Then it induces less euphoria and has a longer duration of action than morphine. Methadone is well absorbed after oral administration. Methadone is biotransformed or metabolized in the liver and excreted almost exclusively in the feces. Then it is very lipophilic, then rapidly distributed throughout the body and released slowly during redistribution and elimination. And this methadone has got a long half-life, and its half-life ranges from 12 to 40 hours, although it may extend up to 150 hours. Despite the extended half-life, the actual duration of analgesia ranges from 4 to 8 hours. Upon repeated dosing, methadone can accumulate due to the long terminal half-life, can lead to toxicity. Overdose is possible when prescribers are unaware of the long half-life, the incomplete cross tolerance between methadone and other opioids, and the titration guidelines to avoid toxic accumulation. And this methadone is susceptible to many drug-drug interactions. This methadone produces less neurotoxicity than morphine due to the lack of active metabolites, because morphine produces two active metabolites. This methadone has no active metabolites. Because of this, methadone will produce only less neurotoxicity. Then this methadone can prolong the QTC interval and can cause torsade D pointers, possibly by interacting with the cardiac potassium channels. So as a result, baseline and routine ECG monitoring is recommended in case of methadone therapy. Moving on to the next drug, which is Pethidine, also known as Nepridine. Lower potency synthetic opioid structurally unrelated to morphine. This pethidine is used for acute pain and acts primarily as a kappa agonist with some mu agonist activity. Then it is very lipophilic and has anticholinergic effects. Active minor metabolite. The active minor metabolite of pethidine is norpethidine, which is potentially neurotoxic, whereas the major metabolite is meperidinic acid along with glucuronide conjugation metabolites which are excreted via the kidney. As they are renally excreted, they can cause accumulation in patients with renal insufficiency. It can cause delirium, hyperreflexia, myoclonus, and seizures. Due to the short duration of action and the potential for toxicity, pethidine should only be used for short-term management of the pain. Short-term management in the sense less than or equal to 48 hours. Pethidine should not be used in elderly patients or in those with renal insufficiency, hepatic insufficiency, pre-existing respiratory compromise, or concomitant or recent administration of monoamine oxidase inhibitors. Serotonin syndrome has been reported in patients receiving both pethidine and SSRIs. Then this pethidine is primarily used as an analgesic and in pre-anesthetic medication. It can also be used to control shivering during the post-surgical recovery period. Transdermal pethidine is used for the management of cancer pain. On the transdermal route, the onset of pain is delayed up to 12 hours. However, on subsequent administration, the analgesic effect is sustained for prolonged periods in patients. Next drug is propoxyphene, which is a congener of methadone. It has the analgesic activity and side effects similar to those of codeine, but less antitussive action. It can be combined with NSAIDs such as paracetamol and aspirin. Its dextro form is found to be analgesic, therefore it is used as dextropropoxyphene. The levo form is found to have antitussive activity. Primarily, it acts through the mu receptors for analgesia. Then this propoxyphene is metabolized into norpropoxyphene, which is reported to have a half-life of more than 30 hours. Accumulation of this metabolite is reported to show toxicity. In moderate toxic doses, norpropoxyphene is reported to show respiratory depression, convulsions, delusion, hallucination, confusion, cardiac side effects, etc. Respiratory, convulsion, and cardiac toxicities are reversed with naloxone. So far we have discussed about the agonist drugs. Now we will learn about the partial agonist, mixed agonist, and antagonist. Partial agonists bind to the opioid receptor, but they have less intrinsic activity than full agonist. There is a ceiling to the pharmacological effects of these agents. Ceiling effect means it is a pharmacological phenomenon that occurs when a drug reaches its maximum effect and increasing the dose does not result in any further benefits or side effects. Drugs that stimulate one receptor but block another are termed mixed agonist antagonists. The effects of these drugs depend on previous exposure to opioids. In the presence of a full agonist, the agonist-antagonist drugs may precipitate opioid withdrawal symptoms. So one important drug is buprenorphine. It is a potent partial agonist at the mu receptor and an antagonist at the kappa receptors. It is very lipophilic and has a longer duration of action. Because of the partial mu agonist activity, buprenorphine provides a ceiling effect, causing less euphoric effects and a lower abuse potential than that of full agonist. Okay, so this is one advantage of buprenorphine. Additionally, the risk of opioid-induced respiratory depression may be lower when compared with full agonist, except when combined with CNS depressants such as benzodiazepines. Then this buprenorphine is available in sublingual, transmucosal buccal, parenteral, subdermal and transdermal formulations. Buprenorphine is approved for moderate to severe pain. Certain formulations, for example sublingual and subdermal, are approved for use in medication-assisted treatment of opioid addiction due to its ability to provide prolonged suppression of opioid withdrawal, the ability to block other mu agonists and less frequent dosing requirements. In contrast to methadone, which is available only at specialized clinics when used for opioid detoxification or maintenance, buprenorphine is approved for office-based treatment of opioid dependence. Then it has got shorter and less severe withdrawal symptoms compared to methadone. This buprenorphine is used in opiate detoxification because it has a less severe and shorter duration of withdrawal symptoms compared to methadone. A 72-hour transdermal product designed to continuously release buprenorphine at 35, 52.5 or 70 microgram per hour is available for the treatment of persistent pain. Because of high lipid solubility, it has an excellent sublingual bioavailability. The typical daily dose for opioid addiction ranges from 4 to 32 mg daily buprenorphine. It may precipitate withdrawal in patients who have received repeated doses of a morphine-like agonist and developed physical dependence. Buprenorphine's respiratory depressant effects are reversed only by relatively large doses of naloxone. Buprenorphine transdermal patches are available in various strengths including 5 microgram per hour, 7.5 microgram per hour, 10 microgram per hour, 15 microgram per hour and 20 microgram per hour. Then it is mainly used for chronic severe pain. It is indicated for the management of pain severe enough to require daily, round-the-clock, long-term opioid treatment and for which alternative treatment options are inadequate. Each buprenorphine transdermal patch is worn for 7 days except during titration. Concern of QTC prolongation. Buprenorphine is metabolized via CYP3A4 and drugs which inhibit CYP3A4 may increase the risk of QTC prolongation and other adverse effects. Cardiac histories and concurrent medications should be evaluated to identify potential risk factors for QTC prolongation when considering buprenorphine. Then adverse effects include respiratory depression that cannot easily be reversed by naloxone and decreased or rarely increased blood pressure, nausea and dizziness. Next drug is levorphanol. It is an optical isomer of dextromethorphan. It is as potent as hydromorphone but longer lasting. It is a mu kappa and delta agonist as well as being an NMDA antagonist. It is metabolized to a 3-glucuronide of unknown activity. Potential for interaction at the glucuronidation enzyme sites with theoretic interactions with NSAIDs, valproic acid, lorazepam and rifampin. It was noted to be pharmaceutically incompatible with aminophylline, amobarbital, heparin, methicillin, pentobarbital, phenobarbital, phenytoin, secobarbital and thiopental. Pentazocine acts as an agonist on kappa receptors and is a weak antagonist or partial agonist at mu receptors. This drug is administered either orally or parenterally, produces less euphoria compared to morphine, but in higher doses respiratory depression, increased blood pressure, tachycardia and hallucinations can occur. For these reasons, pentazocine is rarely used for the management of pain. Pentazocine should be used with caution in patients with angina or coronary artery disease since it can increase the blood pressure. Nalbuphine and butorphanol are mixed opioid agonist antagonist. They have got limited role in the treatment of chronic pain. Butorphanol is available in a nasal spray that has been used for severe headaches, but it has been associated with abuse. In contrast to pentazocine and butorphanol, nalbuphine does not affect the heart or increase the blood pressure. A benefit of all three medications is that they exhibit a ceiling effect for respiratory depression. Coming to other analgesics, so the first one is tapentadol. It is a centrally acting analgesic. It is an agonist at the mu opioid receptor and an inhibitor of norepinephrine reuptake. It is used to manage moderate to severe acute and chronic pain, including neuropathic pain associated with diabetic peripheral neuropathy. And this tapentadol is mainly metabolized to inactive metabolites via glucuronidation and it does not inhibit or induce the cytochrome P450 enzyme system. Dosing adjustment is not necessary in mild to moderate renal impairment. Then this tapentadol should be avoided in patients who have received MAVO inhibitors within the past 14 days. It is available in an immediate release and extended release formulation. So the next one important drug is tramadol. Tramadol is also a centrally acting analgesic that binds to the mu opioid receptor. Then this drug undergoes extensive metabolism via CYP2D6 leading to an active metabolite which has a much higher affinity for the mu receptor than the parent compound. In addition, it weakly inhibits reuptake of norepinephrine and serotonin. Tramadol is used to manage moderate to severe pain. Of note, tramadol has less respiratory depressant activity compared to morphine. Administration of naloxone can only partially reverse tramadol toxicity and has been associated with an increased risk of seizures. Overdose or drug-drug interactions with SSRIs, MAVO inhibitors and tricyclic antidepressants can lead to toxicity manifested by CNS excitation and seizures. Tramadol should be used with caution in patients with a history of seizures. Next drugs, diphenoxylate and loperamide are used for the treatment of diarrhea. Diphenoxylate is combined with atropine to reduce the chance of abusing liability. Defenoxin is a metabolite of diphenolate, which is also being marketed along with atropine as a fixed dose combination. Loperamide shows action similar to that of diphenolate. It exerts its action by interacting with the opioid receptors in the intestine. Abdominal cramps and constipation are the common side effects. Morphine and hydromorphone are short half-life opioids that on repeated dosing reach steady state in 10 to 12 hours. Levorphanol and methadone are long half-life opioids that on an average may need 70 to 120 hours respectively to achieve steady state. Active metabolites such as normeperidine and norpropoxyphene may have longer plasma half-life values than their corresponding parent drugs. Their corresponding parent drugs are meperidine and propoxyphene. So in this image, you can see the plasma half-life values for opioids and their active metabolites. So lastly, we are going to learn about antagonists. The opioid antagonists bind with high affinity to opioid receptors, but they fail to activate the receptor-mediated response. The opioid receptor antagonist examples include naloxone and naltrexone are competitive antagonists at the mu, kappa and delta receptors with a high affinity for the mu receptor but lacking any mu receptor efficacy. Naloxone and naltrexone act centrally and peripherally but have differing pharmacokinetic profiles favoring different therapeutic uses. In opioid-dependent patients, antagonists rapidly reverse the effect of agonists such as morphine or any full mu agonist and precipitate the symptoms of opioid withdrawal. So the first competitive antagonist is naloxone. It is a competitive antagonist at mu, kappa and delta receptors with a 10-fold higher affinity for mu than for kappa receptors. This naloxone can reverse effects of morphine overdose such as respiratory depression and coma within 1 to 2 minutes of intravenous administration. It is also used to diagnose opioid dependence. Naloxone can also be administered intramuscularly, subcutaneously and intranasally with a slightly longer onset of 2 to 5 minutes. However, little to no clinical effect is seen with oral naloxone due to extensive first-pass metabolism. Since naloxone has a half-life of 30 to 81 minutes, a patient who has been treated for an overdose and recovered may lapse back into respiratory depression depending on the opioid ingested and dosage form of that opioid. Therefore, multiple doses should be administered. So much higher doses and continuous administration of naloxone are needed to reverse the effects of buprenorphine due to its high affinity for the mu receptor. The duration of action of naloxone lasts for up to 48 hours. It is used to decrease the craving for alcohol. Naloxone is available in an auto-injector and a nasal inhaler for community distribution for treatment of opioid overdose involving heroin or prescription opioids. Next opioid antagonist is naltrexone. It has actions similar to those of naloxone, but it has a longer duration of action and can be given orally. For example, a single oral dose of naltrexone blocks the effect of injected heroin for up to 24 hours and the intramuscular formulation blocks the effect for 30 days. Naltrexone in combination with the clonidine and sometimes with buprenorphine is used for rapid opioid detoxification. And this naltrexone is reported to cause hepatotoxicity and monitoring of hepatic function is recommended. So let's compare opioid antagonist drugs. Naloxone has low oral bioavailability but a fast onset of action following parenteral administration for rapid reversal of acute adverse opioid effects. Its short duration of action risks the potential for re-narcotization, thus not providing adequate duration of effect coverage for long-acting opioid maintenance or deterrent therapy. Naltrexone is orally effective with a long duration of action, making it useful in abuse deterrent, detoxification and maintenance treatment modalities. Nalmefene, it is a mu opioid receptor antagonist. It is a water-soluble naltrexone derivative with a longer duration of action than naloxone. It is available for use in the United States for the reversal of opioid drug effects. Naloxone and naltrexone can be combined with mu agonist or partial agonist. Naloxone is used with sublingual buprenorphine to prevent the intravenous abuse of buprenorphine. So far we have discussed about all opioid drugs. Now we are going to learn about the drug conversions. With a chronic administration, the ratio of oral morphine is to intravenous morphine is 3:1. Okay, so this ratio is very important during the drug conversions. The ratio of oral morphine is to intravenous morphine, the ratio is 3:1. Hydromorphone is approximately 5 to 12 times more potent than morphine. 10 to 20 milligram of intravenous morphine and perhaps up to 90 mg of oral morphine is roughly equivalent to 25 microgram of transdermal fentanyl. Similarly, 25 microgram transdermal fentanyl is roughly equivalent to 45 mg of oral oxycodone or 12 mg of oral hydromorphone per day. Although methadone has been described as equipotent to morphine, it is now clearer that dosing methadone on a milligram for milligram basis will lead to a life-threatening overdose. For doses of morphine under 100 mg, a ratio of 3:1 may be appropriate, while for higher doses of morphine, a ratio of 20 mg morphine for each milligram of methadone may be appropriate. Equianalgesic dosing of opioids, that is from the intravenous to the oral form of the drug. So you can refer this diagram for the drug conversions among the opioid drugs. So we have completed the pharmacology of opioids. If you have any doubts, you can post in the comment section. Thank you for watching this video. Have a good day.